Good afternoon, everyone. It's a pleasure for me to be speaking to you today, obviously on quite an important topic for any infectious disease clinician in South Africa and indeed around the world. So I'm going to be talking about PCP caused by Pneumocystis jirovecii. So, I mean, as a medical student in the early 2000s, there was a change in the name from PCP to PJP. And I haven't really been sure exactly through the years which term to use. So, I mean, obviously, PCP can stand for Pneumocystis carinii pneumonia, or if we're looking at Pneumocystis, the P and the C from Pneumocystis, and in terms of the jirovecii pneumonia, or obviously PJP. But generally, it seems that in most current medical terminology, we still use the term PCP to describe the pneumonia caused by Pneumocystis jirovecii. And another term that sometimes use, particularly in the older literature, is pneumocystosis. So from now on, I'll be referring to it as PCP, obviously caused by Pneumocystis jirovecii and not carinii anymore. So Pneumocystis was first diagnosed or first discovered by Carlos Chagas, he of the Chagas disease fame, back in 1909. But at that point, he thought that it was part of the life cycle of Trypanosoma cruzi. A few years later, it was identified as a unique organism by Delanos. And then at that point, it was named Pneumocystis carinii, in honor of Antonio Carini, who was an Italian physician who was also one of the pioneers in investigating pneumocystis. In the 1940s and 50s, it was identified as the cause of a perplexing pneumonia amongst particularly premature and malnourished infants in Europe, particularly in Germany. The cause for this was not very clear. I mean, there's been a few historical papers written on theories as to why this outbreak of pneumonia occurred, particularly in Germany, but it was a time that pneumocystis gained some notoriety. If we look at this table, it shows some of the we can see now in the 1950s, there was a huge number of papers published. These are just the number of reports, not particularly the number of cases within each report. And there's a huge number, a total of 135 between 1955 and 59. So it was a massive issue at the time. Then in the 60s and 70s, PCP became well known as a cause of pulmonary disease in immunocompromised hosts. This was as more and more people were being exposed to other significant immunosuppressive therapy and chemotherapy associated with mainly treatment of malignancies. And then obviously in the early 1980s, with the onset of the HIV epidemic, pneumocystis became particularly well known and particularly obvious. And back then, we didn't really know that HIV was the cause of the immune suppression associated with development of PCP. And these early papers chronicle the initial presentation of the series of pneumonia back in the early 1980s, before we actually had identified HIV. So where PCP is mostly HIV associated, we're seeing a reduction in incidence rates around the world. That's mainly because obviously PCP is associated with significant immune compromise, and as people start on antiretroviral therapy, they become less susceptible, and so the incidence is decreasing. But where PCP is in parts of the world where HIV is not the main cause, or HIV-associated PCP is not the main presentation of the disease, it is actually increasing, and that's because of people living longer and more solid and hematological malignancies, solid organ transplants with associated significant immune suppression, and then the other autoimmune and inflammatory conditions that are treated with immunomodulatory therapies. So as an indication of this, we can see that in the UK, PCP cases have increased between 2000 and 2010. And this is amongst those are HIV negative. If we look at a recent report from Spain, amongst HIV negative individuals between 2008 and 2012, we see a reduction, or we see an increase in the number of cases. But amongst HIV positive individuals, we're seeing a decrease in the number or the incidence of cases over that same period of time. In the US and Canada, where the PCP in this study was associated with HIV infection, we see that as a spread of antiretroviral therapy has increased, so the incidence of PCP has decreased over time. But within sub-Saharan Africa, we're obviously seeing a decrease in PCP generally, but it still has a huge burden of disease. This is a meta-analysis and systematic review by Wasserman et al. And shows that a pooled prevalence of about 15.4% of PCP amongst the HIV-infected population in sub-Saharan Africa. If we look at the characteristics of these individuals, most of them had obviously low CD4 counts at the median of about 50. Most of them were not on cotrimoxazole prophylaxis, and most of them were also not on therapy. But also what was interesting is the percentage of overall coexistent other opportunistic infections associated with PCP were up to almost a third of PCP cases had other coexistent opportunistic disease, and the most common of those was obviously TB. Then in a more recent study looking at people who are HIV infected with signs of respiratory infection, where a sputum multiplex PCR was done looking for mycobacterial, viral, and bacterial causes of pneumonia, we see that PCP was present in about 10% of individuals. So it still has a significant burden of disease in South Africa, and we are all very aware of that working as clinicians in South Africa. Outcomes for PCP are generally still pretty poor. This is a study from, I think, Groote, which showed that overall mortality, 90-day mortality was close to 40%. And if you include those that were admitted to ICU and those that were admitted to the ward, obviously ICU mortality, those that were admitted to ICU had a much higher mortality than those admitted to the ward, but overall still a very, very poor outcome generally from PCP infection. So Pneumocystis jirovecii was initially thought, or was initially classified as a protozoan, and now it's obviously well known to be a fungus, but it is atypical. The reason why it's atypical is because it is different to the other fungi in that the major sterol in the cell membrane is cholesterol rather than ergosterol. The shape of the organism and the fragile cell wall make it different, and it doesn't have any chitin in its cell wall. Also, it's unable to be cultured in vitro, and that poses significant challenges to determining some drug resistance and other issues as well, including diagnosis as well. And then it's also highly host dependent and adapted to its host species. So each Pneumocystis species can actually only infect one host species. And this was one of the reasons how the nomenclature was changed from Pneumocystis carinii, which is the organism that infects rats, to Pneumocystis jirovecii, the organism that infects humans, and that it was noticed through genetic analysis that these organisms were significantly different, and one form of Pneumocystis cannot affect another species. So this is just an image showing the difference in other fungi such as Candida in terms of the ergosterol and the cholesterol being different. Also, the fact that there's an absence of chitin in the Pneumocystis cell wall. What's different also is between this Pneumocystis cyst form and troph form, which is the presence of this beta-D glucan component. So we know that Pneumocystis is ubiquitous in the environment. It hasn't always been clear exactly whether the organism exists in a particular reservoir outside of humans, and whether this reservoir is in other mammals or whether it is in the environment. So initially it was thought to be a zoonosis, but as we've learned more, we know that Pneumocystis cannot cross-infect to other species, and there's also significant genetic differences between the different species of Pneumocystis. There's currently no evidence of environmental reservoir. Previous studies have shown that they've been able to pick it up via PCR and some water samples, some soil samples, but these have all been linked to close contact with humans. The cyst form is likely the infectious form, and it's generally going to be passed via inhalation. So spread of cysts from one individual to another. And this has been proven in multiple ways by, in one way, in animal models by giving animals that are, by using mice, giving them an echinocandin, which inhibits beta-D-glucan synthesis, which is only part of the cyst form, and then proving that those animals that have been treated with echinocandins cannot transmit disease to other mice, because the cyst form is the form that is required for transmission. But what we also know is that both immunocompetent and immunodeficient hosts can become reservoirs, and both can transmit infection. These transmitters can be people that are colonized with Pneumocystis and those who have active disease. So in terms of a model, we can see that individuals can those that are immunodeficient, say someone who comes in with PCP in the ward, can transmit it to someone who is healthy, who may transmit it to another healthy person, or may transmit it to another immunodeficient person. So immunodeficiency is not required in order to be a transmitter. The spectrum of disease is pretty wide, although it's all mostly associated with the pulmonary system. The presentation is generally of a subacute pneumonia involving cough, dyspnea, and fever, and usually lasts days to weeks before presentation, typically around 3 weeks before people present to the hospital. Radiographic features are quite varied, opposed to the normal diffuse bilateral interstitial pneumonia that we would see. You can have multiple different presentations on chest X-ray, which could be asymmetrical or lobar in presentation. Nodular may also form cavities, may be associated with a pneumothorax or with a pleural effusion. So it's always important to remember that. Extrapulmonary manifestations are very rare. They can be seen generally only in very advanced HIV and those receiving second line, less effective PCP prophylaxis, including dapsone and pentamidine. And when there is some extrapulmonary manifestations, it typically includes the eye, ear, thyroid, and may also include the spleen, liver, or lymph nodes. Bone marrow involvement can occur, and systemic dissemination is very rare, but has been seen. Diagnosis of extrapulmonary manifestations generally made by proved by visualizing the cysts in tissue. So in terms of diagnosis, generally it requires, a definitive diagnosis requires visualization of the cystic or the trophic forms of the organism, normally in respiratory secretions. Can be done via a general stain, which are less sensitive. There are multiple different stains, including methenamine silver, which is what I understand to be the most common. And also using fluorescein labeled monoclonal antibodies, which is more sensitive. PCR is typically used as well, and this has different gene targets. The MTLSU gene is the one that is typically most targeted in the PCR assays. It's a lot more sensitive than microscopy, but it cannot distinguish between colonization and disease. Quantitative PCR has a better ability to do that, but the cutoffs associated with the colonization and disease have not been reliably established yet. So at the moment, it's quite difficult to make this differentiation. We do have, sputum, different specimens can be used and may require tissue in some events. Bronchoalveolar lavage, endotracheal specimens, as well as sputum, and then tissue could be required. And then useful biomarkers can be used, such as beta-D-glucan, particularly in the setting of HIV, is particularly useful, although non-specific. Increasing specificity is through the use of combined testing, which is becoming a bit more popular, using both PCR and a biomarker such as beta-D-glucan. It's always important to consider all the differential diagnoses, particularly in individuals that are so immune suppressed to be susceptible to TB, they're also susceptible to other infectious diseases. And as we know now with the COVID epidemic, SARS-CoV-2 is particularly difficult to distinguish in immunocompromised individuals from PCP, influenza, and other causes, and CMV as other causes of viral infection. And then we've got to consider mycobacterial causes, other fungal causes, some atypical bacterial causes, and malignancy as well on your differential diagnosis. And it can be quite tricky to differentiate these in someone that is acutely ill and sometimes intubated. So in terms of treatment of PCP, there are a lot of different compounds that are active against PCP, either in vitro or in vivo. Generally, the ones that circled or in this box here are the ones that have had the most research and use associated with them, and in addition to pentamidine, which is not readily available to us. But generally, first-line treatment of PCP involves trimethoprim sulfamethoxazole, or otherwise known as cotrimoxazole or Bactrim, and this has been established as the first-line treatment since quite early on in the PCP pandemic, early on since the mid-80s. Generally as a dose of 15 to 20 milligrams per kilogram per day, divided into 3 to 4 doses, and treatment is generally for 21 days. So evidence for this has been established over the years, and not many randomized controlled trials, but there is significant evidence that cotrimoxazole is the treatment of choice from early on. Pentamidine was used quite extensively, but it was from relatively early on, it was quite obvious that cotrimoxazole was more effective. And we can see here, if we look at survival, it was higher amongst those in this early study back in 1988 amongst those receiving cotrimoxazole versus pentamidine. There was some early optimism about using atovaquone. This study looked at using atovaquone versus sulfamethoxazole, trimethoprim, which showed that trimethoprim cotrimoxazole was definitely more effective than atovaquone, although atovaquone has its use, as I'll explain a bit later. This study was from 2009, looking at looking at the efficacy of first and second line treatments for PCP. What was important was that Bactrim or cotrimoxazole was associated with less, if we can see here, less toxicity switch and less failure switch away from that treatment as a first line treatment regimen in comparison to the other pentamidine and clindamycin primaquine. And if we look at the survival, we've got, obviously, cotrimoxazole has its issues. It's a combination of two drugs, trimethoprim, which is a dihydrofolate reductase inhibitor, and sulfamethoxazole, which is a dihydrooptyrate synthasase inhibitor. And together they work synergistically to interrupt thymidine synthase. And by doing that, inhibit DNA synthesis of the organism. So some of the adverse effects we know quite well: rash and fever, GRT, the cytopenias, bone marrow suppression, quite significant adverse effects that are associated with use of cotrimoxazole. So what about alternative regimens? So there are alternative regimens, but it also depends on how severe PCP treatment is. Generally, in trials, they've used a mild, moderate, or severe grading in terms of the AA gradient. So in mild to moderate disease, options can include trimethoprim and dapsone, if you have trimethoprim as a separate drug, primaquine and clindamycin. atovaquone, which is exclusively used for mild disease, and then pentamidine. Pentamidine obviously has quite significant side effects and is very difficult to get hold of. We don't have access to it here. And in general, all patients should receive 21 days of therapy, whether they're HIV infected or not, according to most current guidelines. So in this study, they were looking at mild to moderate disease. There was no clear difference, although it was a small study of 97 people comparing cotrimoxazole versus dapsone with trimethoprim and clindamycin primaquine. There was no significant difference in efficacy of any of these against each other. So there's no clear current evidence that would suggest that either of these in mild to moderate disease is superior to the other, although expert opinion generally suggests that cotrimoxazole be the treatment be the first line treatment of choice. So atovaquone can be used only in mild disease. There was one study done a long time ago, which did not use a comparator, but used atovaquone at a few different doses. It reported that all patients survived, but there was actually quite a significant failure rate if we look here. But it is still an option if you have access to it as a drug on its own for cases of mild disease. But generally, there is another option available. There's very little reason to use it. For severe disease, there's really only evidence for the use of primaquine and clindamycin in addition, or as an alternative to cotrimoxazole, and then pentamidine, which I said is associated with quite significant side effects and also is not easily available. If we look at alternate regimens, what we can see is that by first-line treatment, in terms of alternate regimens, clindamycin primaquine is superior to pentamidine. In terms of corticosteroids and PCP, there have been multiple studies that have investigated the role of corticosteroids. One systematic review and meta-analysis has pulled those together and looked at the benefit of corticosteroids in terms of one outcome of death at 1 month, which shows a significant protective effect of steroids. Other is outcome of death at 3 months, which was also significantly protective. And then also looking at mechanical ventilation, showing that a reduced incidence of mechanical ventilation at 1 month in individuals that were given steroids. So the role of corticosteroids in PCP is pretty clear. Generally, it's thought to reduce the inflammatory response that is present in breakdown of organisms on initiation of treatment, which quite often causes a deterioration in clinical condition around about 3 to 5 days after initiation of PCP treatment. So as a general guideline, adjunctive corticosteroids should be given to moderate to severe disease, and that's in the studies was quantified as having a PaO2 of less than 70. Generally, it should be given as soon as possible and definitely within 72 hours. So treatment failure. Treatment failure is generally defined as a lack of improvement or worsening of respiratory symptoms or respiratory function as documented by arterial blood gas, and generally after 4 to 8 days of anti-PCP treatment. And this is important that it is defined as being after 4 to 8 days, because what we can generally expect there to be, particularly in the absence of corticosteroid therapy, a deterioration around 3 to 5 days of therapy, as I mentioned before. About 10% of treatment failure cases can be attributed to lack of drug efficacy, and up to about a third of patients, this can be due to treatment limiting toxicities associated with the use of drugs such as cotrimoxazole. And this is from a study from back in 1996. It showed the incidence of rates of dose-limiting toxicity associated with clindamycin and primaquine, also using cotrimoxazole and also dapsone with trimethoprim as well. Whenever you have a case of treatment failure, it's always important to consider this graph that I showed, or this table that I showed to you earlier, which shows that generally there's quite a high incidence of concomitant other opportunistic infections. So it's always important to consider whether this deterioration or lack of improvement is due to something else, i.e. another concomitant medical condition being co-infection, or pneumothorax, which is common in obviously common in PCP, and PE, which would also be quite common in PCP. Otherwise, there's no clear guidelines on treatment of management of failure, but poor response to cotrimoxazole, if it's been given orally, an approach would be then to change it to being given intravenously. And then obviously if there's either poor efficacy, you've excluded these other causes, or you have treatment limiting toxicities, it would be an indication to switch to an alternative therapy. So that brings us to the point of considering the entity of cotrimoxazole resistance. We know that there have been mutations in the dihydroopteroid synthase gene, DHPS, that have been described for many years. And this has also previously been attributed to exposure to sulfur and sulfone drugs, particularly in the form of use of drugs for PCP prophylaxis. And because, as I said earlier, PJP can't really be grown in media in the lab, it's in vitro drug susceptibility testing is unable to be performed. So we rely on other measures to look and see whether patients are clinically failing due to resistance to therapy. But so far, there's been no clear data linking mutations in this gene to treatment failure. Initially, there was thoughts that there was but we haven't really, and we're still waiting for some more data on this. We haven't really proven that these mutations in the gene are actually associated with treatment failure. What this table shows is that exposure to sulfur prophylaxis increases the relative risk of developing these resistance mutations. And the longer individuals were on the therapy, the more likely they were to have the mutations. But this was the most thorough paper that's been produced so far, looking at whether these mutations are actually associated with worse outcomes. There was a group of patients, some of which had wild type pneumocystis and others that had a mutation, and they looked to compare whether when they were both treated with cotrimoxazole, whether one group had worse outcomes compared to the other. And what we see is that actually, if we look at poor response to initial treatment, it was actually much higher amongst those who had wild type versus those that had the mutant. So there may be different reasons for this, but at least it doesn't show that those who had the mutant had higher rates of treatment failure. So in the case that you do have a case of poor response with clinically, with treatment failure that you could define by the criteria I mentioned before, what are your options? So there's been a few meta-analyses done looking at different data, looking at different studies, and generally this one showed the use of what the previous drug used was, and then the response to treatment. So failure on cotrimoxazole and then use of pentamidine as an example, basically showed that the response was much better amongst those given clindamycin primaquine as salvage therapy compared to any of the other drugs. That was then also confirmed by this study looking at the same thing, looking at pentamidine using either clindamycin primaquine, pentamidine, atovaquone, or cotrimoxazole as salvage therapy, bearing in mind that most of these cases would have had cotrimoxazole as their first-line therapy as well, clearly showing that clindamycin primaquine is the drug of choice. And this study, again, I mentioned it earlier, but this is now looking at survival after second-line treatment, showed an advantage to using clindamycin primaquine up here compared to pentamidine. So generally, following failure of cotrimoxazole therapy, primaquine and clindamycin is a recommended therapy. And this is good for us, seeing that we actually don't even have much access to pentamidine. If individuals were not given cotrimoxazole as their initial therapy, you may consider, mainly because of sulfur allergy, you may consider other options. If they have mild disease, you could use clindamycin and primaquine, as we mentioned, or atovaquone, or trimethoprim dapsone if you have that available. But in severe disease, you're quite restricted to what your options are. And one of the options would be to consider desensitization for cotrimoxazole if it's safe to do so, and i.e. if there haven't been any previous very severe reactions. If there was only a skin reaction, you may consider doing a rapid cotrimoxazole desensitization protocol, and that's described by the team from UCT in the link at the bottom of the page. So what are other outstanding issues related to cotrimoxazole? One would be that actually the dose that we use is not clearly defined. Well, it's clearly defined, but hasn't really been clearly researched in terms of randomized control trials. Some studies have shown that using reduced doses of maybe about 10 milligrams per kilogram per day, you could actually reduce adverse events and have equivalent outcomes. But this hasn't been extensively studied in bigger studies. So the actual dose for cotrimoxazole is possibly something that may need more research and may be able to be optimized. It's also not clear whether the dose should be different between PCP associated with HIV and non-HIV associated PCP. So what about other drugs that are available or possibly may be useful in the treatment of PCP? As I said, we are quite limited in terms of what options we have. That would include these drugs, which would possibly include the echinocandins. So there's a mixed use of echinocandins, but not that much evidence for them. There's some evidence from in vivo studies that have showed that in rats and mice, caspofungin, as an example, has been effective. This has also been shown in vitro for Pneumocystis jirovecii, but obviously not clearly in clinical practice. The problem with the echinocandins is that the drug is active against the cyst, but not the trophic form, mainly because they target beta-D-glucan. And as you can see from this image, beta-D-glucan is absent in the trophic form. Of reports of use of caspofungin as an echinocandin in the literature, there have been multiple different studies that have reported efficacy with use of caspofungin, either alone or in combination with cotrimoxazole, but the numbers are very small. As we can see, a lot of them are just case studies. Here is a group of 14 patients, but there's clearly not enough evidence yet to suggest the use of echinocandins, although there are a couple of clinical trials currently running, and possibly the use of echinocandins in combination with other drugs such as cotrimoxazole may be useful, but we should find that out pretty soon. Sulfasalazine, there's been a little bit of research on it as a adjunct in the treatment of PCP. In mice, it has been shown to attenuate pulmonary inflammation and assist with improving fungal clearance. And this seems to be driven by the effect of sulfasalazine on altering T cell function and macrophage responses, where it shifts the response to an M2 response. Also, there are a few clinical trials involved, but no clear evidence as yet. But the basis for, the theoretical basis for its benefit does exist, but we still need a bit more evidence. If we look at the role that steroids have played, it's not implausible that other immune modulatory drugs may assist. Just one or two other topics with regards to PCP treatment. One is the timing of ARV initiation in those that are HIV infected. Most patients who present with PCP are not on antiretroviral therapy or possibly have defaulted. The best study that we have is this study from PLOS ONE in 2009, which looked at either early or deferred initiation of treatment in those with individuals that are ARV naive presenting with an opportunistic infection. And most commonly, the opportunistic infection was PCP, although it wasn't exclusively. And in this study, there was a clear benefit for early treatment, so early initiation of ART, so within 2 weeks. So that's currently the guideline that ART should be initiated within 2 weeks of starting PCP treatment. IRIS is not common. There's another small study that was done which just showed that individuals, it was only a group of about 40 patients that were initiated early, didn't have higher rates of IRIS compared to those that were started later. Within the 2 weeks is a matter of debate as well, like when should it be at 14 days or should it be at day 0? Generally, I think the practice is dependent on the clinician, and what makes sense is to make sure an individual is coping on the other treatment for PCP before they are given the antiretrovirals, but generally the earlier the better. Other regimens for prophylaxis include dapsone, atovaquone, and then a combination of dapsone, pyrimethamine, and leucovorin, and then obviously aerosolized pentamidine as well, which is not easy to get hold of and is not available here, but can be found overseas. In terms of cotrimoxazole, the current suggestion is for using 1 double strength or 2 single strength tablets daily. This can also be given as 1 single strength tablet daily, or 1 double strength tablet or 2 single strength tablets 3 times a week. And they seem to be pretty much equivalent. Dapsone also can be given daily or as a BD dose. Atovaquone can also be used. And then finally, will we see a vaccine for PCP anytime soon? Sorry about that. Well, there's still a lot of work to be done. One of the difficulties is creating a model to use and test a vaccine. And one of the problems is you need to vaccinate animals and then be able to immunosuppress them in order to determine whether a vaccine would actually be effective in the type of population that is usually susceptible to PCP. And so there are different vaccines that are being designed, some that are inactivated whole organisms and others that are subunit vaccines based on different Pneumocystis, jirovecii genes, but they are still a long way from development, but there are a lot of them in development. So hopefully we'll see something along this line pretty soon. So with that, I'd like to stop and let's find out if there are any questions.
Thanks, Lyle. That's really great. So I've taken the prophylactic measure of unmuting Nilesh, who is our expert on it, and John Freen as well. So one issue that always comes up is this issue of of resistance, because it's so very hard to know. As you say, you can't culture it, can't do anything like standard susceptibility tests. I mean, in the one paper that I think John, you were part of, I mean, there was a lot of mutations found. It was over 50%, I think, in the cohort. Mostly from Barra, if I'm not mistaken. But as you said, it's not always clear whether that translates into clinical failure. So whether it's just we just don't know enough about what the mutations mean, or whether it's sort of low-level resistance that are probably our dosing, as you say, with Bactrim maybe slightly higher than is required, and maybe that's enough to overcome. I don't know. It's tricky. It's a tough thing, and as you said, it's an eternal question. In terms of the patient who's not getting better, is this resistance, and it's almost impossible to tell. I must be honest, in my own practice, if we ever do think of resistance as a possible mechanism, I always actually keep the Bactrim on as well. So I add a second regimen simultaneously, because as you said, that Bactrim is the best treatment, and if it's not resistance, and there are many other possibilities, you've then maybe made it worse by switching. I don't know if other people have thoughts. Nilesh, what do you think? Sorry, I see you've unmuted, which is great.
Hi, Jeremy. Nice presentation, Lyle. So yes, I agree. It's not that clear what those mutations really mean, and whether they translate to clinical failure. Jeremy, as you say, there are a multitude of reasons for treatment failure, and that could include co-infections. And I think that's a really important point also. In Sean Wasserman's analysis, I think about a third of patients with PCP had other infections, TB, obviously, and various other things. So I agree with keeping on the cotrimoxazole and obviously then looking for other reasons for failure. Resistance is not always going to be the answer.
Yep, agreed. And for example, those who in practice have access to LAMs and that would really do them on every single patient in this country who comes in with BJP, because we find a lot of coexistence of TB. We do that at Helen Joseph, and about a third of our patients have LAM positive. Most of it, which is TB, occasional MAC. Of those who come in with PJP, so that's just routinely looking for them. And as you say, Nilesh, there's a lot of other stuff that goes on as well beyond TB and HIV. John, you've got your hand up. Do you want to go ahead?
Yes. Yeah, so that mutation study was published quite a long time ago, but there's been no real, concrete evidence around that, as you say, as everyone else says. So one sort of confounding factor is the question, and Lyle touched on this, the question of infection versus colonization, and the difficulty of deciding on what sort of copy number is significant and distinguishing between those two. And although there's quite a lot's been published, but a lack of standardization is a main problem. So it's very difficult to compare, in fact, impossible to compare between studies where it's not clear what the starting specimen volume was, for example, or the volume of the DNA extraction. And so you get these wildly varying copy numbers, which are given in individual papers as the cutoff, but you can't really translate between any of those.
Yeah, it's a great point, because I was actually going to ask about that. The sort of, a couple of years ago, there was some flutter in the literature about semi-quantitative PCRs, as in sort of a cutoff level over which colonization was much less likely. And that, I mean, it makes sense in concept, but as you say, if you're not standardizing for the sputum sample or the volume even of stuff, it's very, very hard. It's not like blood where you can take a standard amount. Yeah, very, very tricky. Kim, you've got your hand up.
Hi, thanks, Lau. It was a great talk. So I just wanted to make 3 comments. The first one relating to the resistance that we've just been discussing now. So I found it quite interesting that your source already said you would consider treatment failure after 4 days, Lau, because I think that's pretty quick to expect a response from PCP, and I would certainly want to wait a little bit more before considering the treatment failure, obviously whilst making sure that one has excluded other opportunistic co-infections, and that the dose of your Bactrim, etc., is right and they're actually getting it, etc., etc. So we were always taught that you really need probably 6 or 7 days of treatment before all of a sudden the patient starts responding. So Nilesh, maybe you can just say something about that. What do you think about 4 days of treatment?
Sorry, Kim, did you say 4 days of treatment and then no response at that point?
Exactly. So thinking about drug failure after 4 days. That seems very fast to me.
Seems a bit soon. Yeah, it does seem a bit soon, Kim. I mean, I wouldn't respond and consider that treatment failure quite as soon as that.
Yeah. So I think we always used to say if by day 6 or 7, then one would, then start thinking about treatment failure rather than so early on. But I mean, I accept that one needs to start, thinking about it.
Kim, I just think that, I mean, it's probably worth thinking about, you know, you'd probably expect some level of treatment response, you know, moving in the direction of improvement.
Sure.
I wouldn't consider that complete treatment failure at that point.
No.
But maybe consider, you know, other causes on board at that point.
Exactly.
If the patient's not moving in the right direction.
Yeah. So that was just one point that I found interesting, that reference of yours said after 4 to 8 days, Lau. So
yeah,
the
I mean, they mentioned 4 to 8 days, but one thing they may say is there actually no clear guidelines for kind of treatment failure, and that what they would do is consider changing treatment at about 8 days, but that you would consider it from between 4 to 8 days, and that you should start considering it between that period. But that they actually considered 8 days to be the point that they would actually.
I mean, I think basically the point is that it's not a bacterial pneumonia where after 48 or 72 hours of antibiotics, one really expects to see a good improvement in the patients. This takes a little bit longer to respond.
Sure.
So the second thing I wanted to say was that PCP is so interesting because it seems like people are probably infected in childhood and get the infection under control and then reactivate as an adult when you're immunosuppressed. And they've looked at the types of PCP in immunosuppressed adults with pneumonia to try and work out where the infection occurred. And in the vast majority of people, the infection and the strain of PCP, which was recovered, was linked to the patient's birth site and not necessarily the city where they were living in when they got sick. So it's very interesting that you get infected as a child, control it, and maybe just keep a little bit of it, like TB, and becomes latent and then reactivate it later with the strain that you were infected with as a child. That's just something interesting. And then the last thing I wanted to say is that in HIV negative people, the most common risk factor for developing PCP is having steroids in the 4 weeks prior to infection. And that's very interesting because in moderate to severe disease, like you showed us, we use corticosteroids to improve the hypoxia. So it's a double-edged sword. And always remember in the HIV infected, because we never forget, I mean, we never remember PCP in these patients who are immunosuppressed but HIV negative, to look for PCP, especially in those who've had corticosteroids prior to the development of the pneumonia and hypoxia. Thanks, Lau. That's all I wanted to say.
Great, thanks very much, Kim. Yeah, I was going to say we see a couple of them a year at our hospital here. You know, usually rheumatology patients who've been on steroids for their rheum condition and who come in HIV negative with PJP, and it's interesting. The teaching usually is that the HIV negative ones are more aggressive and they come in, you know, profoundly hypoxic and with a shorter history. And it's now thought that some of that kind of vignette of it being more aggressive than HIV positive was just a lack of recognition early. So in other words, they're just likely to go undiagnosed for longer and so present a bit more acutely. So as recognition has improved over the years, the incidence of severe PJP in HIV negative people has actually gone down a bit as a proportion of the total, which is interesting. Lauren asks about in the studies, Lyle, about the patients who fail first-line treatment. Those switch studies where they switch to a second-line regimen, did they continue the first-line regimen, or did they just abandon it and move to second-line?
So some of them were done in addition to Bactrim or to cotrimoxazole, but most of those were switch studies where they then changed. So and some study they kept the original and then changed, and it was also dependent on the reason for treatment failure. Most of them, like I said, 30% of them are associated with drug-related toxicity. So often the failure wasn't so much actual lack of efficacy, but those that it was due to having to change due to other reasons, and obviously then they had to switch completely away from the other drug. But within those that they did did think that they had actually failure of efficacy, having ruled out the other causes, they generally switched them across to a new therapy.
Oh, great, thanks. Kim, you've got another question?
Sorry, I just thought about something. So we often, in patients who we weren't sure that the Bactrim was working and wanted to give them second line, or in patients who couldn't tolerate Bactrim. And because trimethoprim was not really available, so we couldn't give dapsone and trimethoprim, some people used to give dapsone and clindamycin. And I was just wondering if anybody knows what that combination does, if that's superior or non-inferior to dapsone trimethoprim or clindamycin primaquine. Does anybody know about that?
I definitely didn't read anything about using dapsone and clindamycin. In all the cases where they've used clindamycin, they've used it with primaquine, and in cases where they couldn't give the primaquine, because obviously primaquine has to be given orally, where they couldn't give that component, they then had to shift completely. The guidelines, at least from the US, would say shift completely to pentamidine. If you obviously have it available, they didn't suggest at all, and then adding dapsone. But I'm not, so that from what I've read, that wasn't considered a combination.
Thanks very much. And then the Nosisa brings up the eternally vexing question about CMV co-infection with PJP. And I think that, it's very hard to prove, obviously, co-infection as opposed to just CMV shedding more incidentally. And I think there's also a bit of a difference in terms of the adult and the pediatric practices in general, in terms of how aggressively to treat that. I don't know, Lau, what's your opinion, and have you seen much on that in the literature recently?
I mean, I saw from that paper by Wasserman that they showed that there were CMV co-infection was around 1 to 2%, I think, of cases that they saw. I mean, the difficulty is obviously teasing it out. We've had these debates a few times, what the relevance or usefulness is of the CMV viral load in someone that's so significantly immunosuppressed. And sometimes when individuals have got a positive viral load for some reason, and they've got this clinical picture that looks like a PCP that's not responding to therapy, then sometimes empiric therapy for CMV is added. I didn't find any evidence or any. I wasn't looking for it specifically, to be honest, either. But I didn't see anything mentioning particularly how to separate them, and any trials where they actually used empiric or CMV therapy, and whether there were any beneficial outcomes with them.
Yeah, I mean, it's such it's the perfect confounder in many ways, because you're going to have a rise in CMV shedding everywhere in the body, both in the blood and the lungs, whenever you have severe disease in general, and of course, especially once you start giving steroids. And so finding it there doesn't mean a huge amount, but then at the same time, there's no reason why you can't have co-infection between any two pathogens. And there is such a thing as CMV, pneumonitis, and there is such a thing as PJP. So the two of them could coexist. But the problem is, of course, detecting CMV in, say, bronchial washings or even in the blood at a non-horrendously high level is just, that you're going to overcall that so much and be using so much ganciclovir unnecessarily. But it's very hard, of course, to prove, the alternative. So it's very, I mean, to me, this is crying out for an RCT in the HIV literature of actually to address this and randomly give ganciclovir, because there's certainly an association between the detection of CMV in the BAL fluid and the blood and poor outcomes. But whether that's causal is a nightmare. I mean, in terms of trying to tease it out. And then I'm just looking down. So some people WhatsApp me, some people put in the chat and things. We mentioned most of it, I think, in terms of the questions that have come up. And yeah, I suppose just one other point, just in clinical care. I mean, as you said, there is this mild PJP disease which doesn't need steroids, and the X-ray may be normal, for example, and the lung findings very minimal. And it's just interesting to, I mean, we see almost none of that in clinical practice. And I think the challenge is the ones that are bad enough to come to hospital, especially in the state sector, are bad enough that I would not expect the X-rays ever to be normal, put it that way. They're hypoxic enough. Whereas the mild cases, you just are so hard to diagnose as an outpatient. What are you going to be doing to diagnose them? So it's weird. I mean, just the spectrum of PCP disease in this country is almost none of it is mild. And yet, of course, it must all start mild, to get to severe. So we must be missing it, but at the same time, it's very hard to know what to do about that, because if you're not hypoxic and you're not particularly, massively symptomatic, it's very, very, especially if the X-ray can be normal, it's very, very difficult. Kim, you've got your hand up. Is there another comment? Kim?
Sorry, no, I've just forgot to take my hand off, sorry.
Sorry, I muted myself. Lyle, that's really good. Sorry. People have sent in questions. So they're asking about how to tie the treatment failure to the worsening we see around day 7. So we don't normally see worsening at day 7. I mean, the natural history in the 90s, when this was treated without steroids and before that, was that people would get worse over the first 3-4 days. And that seems to be worsening due to the inflammatory response elicited by killing the organisms in the lung. And so hence the steroids, which is also why it takes a while to improve, as you said, Lyle. If the natural history is to actually worsen on treatment, we can attenuate that to a large degree with steroids, but you wouldn't expect a huge improvement early. It's not, as Kim said, like a pneumonia. So I hope that's answered that question. And then, yeah, I think that's pretty much it. But thank you, Lyle. We've, as you can see, had a lot of good time in terms of concepts. One person just has sent in a question now saying, is there such a thing as PJP iris? Yes, there is, but as Lyle says, not very, very common, but it has been well described in terms of that. But thank you, Lyle. You've done really well, and we've got some great discussions. I mean, it's such a common condition, and yet it's still got a lot to teach us, I think, in terms of much of the rest of HIV medicine, in terms of various therapies and that. And as you said, I mean, there just is this group of PJPs who's severe enough that they just don't get better. We've all faced them, and that appears to be partly pulmonary fibrosis, partly other things, but there's still a lot, I think, in terms of therapies that we need to get our heads around. Thank you very much, and thanks very much to all also who contributed, Nilesh and John and Kim and others who've contributed the expertise.